Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. Now, if you are hearing this right now, then you are not currently a Journal Feed subscriber, and so you will not be receiving the full Journal Feed podcast, only getting a portion of the past week's articles. Don't worry, all good articles. But if you would like to get full access to both the podcast and the blog, you'll have to become a member. All the details for that are journalfeed.org. And remember, we never want money to be a barrier to better patient care. So if you're having trouble affording a subscription, just get in touch. We'll help you out. This is the audio version of the past week's summaries, which this week were brought to you by our authors, Laura Murphy, Jason Lesnick, Doug Wallace, Samuel Ahulu, and Clay Smith. Okay, we're going to skip straight to the second article, titled Guidelines for Reasonable and Appropriate Care in the Emergency Department, GRACE-4, Alcohol Use Disorder, Cannabinoid Hyperemesis Syndrome, and Management in the Emergency Department, out of the journal Academic Emergency Medicine. All right, guys, so we've had GRACE 1, 2, and 3, and now it's time for GRACE-4. These ones always pop up. I never know when GRACE guidelines are coming, but I appreciate it when they do because they tend to be very practical. They're addressing things that I care about, and the methodology is solid. Real kudos to these writing teams, really. They had someone with PhD expertise kind of be the main author and the main coordinator, and then they recruited other people with other expertise in the same field to help advise on these guidelines and discuss all the literature and come to great conclusions. Then, once they'd done some work, they also had patient representatives involved to see how the patient experience was and what they thought of the data that they were finding, and that is really nice to see. It's kind of invaluable. So they sought to answer a few questions and then provided recommendations. The first question was, does adding phenobarbital to benzodiazepines in alcohol withdrawal syndrome improve outcomes? The second question was, does prescribing anti-craving medications improve outcomes in alcohol use disorder? And then lastly, is there a benefit to treating cannabinoid hyperemesis syndrome with dopamine agonists and capsaicin? So they do a thorough review of the literature as well as panel discussions, and then they were able to come up with 7 recommendations, which were full of great advice as well as best practice recommendations alongside their recommendations, just things to add a little bit on top of stuff so that you're practicing well. Keep in mind though that all of these recommendations were based on low certainty or very low certainty evidence. All the same, this is the best we've got. All right, so recommendation number 1. In adult emergency department patients with moderate to severe alcohol withdrawal who are being admitted to the hospital, they suggest using phenobarbital in addition to benzodiazepines compared with using benzodiazepines alone. This is nice to see. I like phenobarbital as a drug. It's very interesting. They only make this recommendation for admitted patients, which is a bit of a shame, unfortunately. We don't have a lot of evidence concerning phenobarbital use in patients who are being discharged. Although they do comment on this a little bit, there are some studies in patients who have been discharged from the emergency department, and they do quote less ED return visits. So there's some data out there to support this use. They also showed less mechanical ventilation, less ICU admissions, and shorter lengths of stays when you were using phenobarbital plus benzodiazepines. That's pretty good for me. They couldn't necessarily recommend a specific dosing strategy, but it seems that 10 milligrams per kg as a starting dose was pretty popular and is used in some studies. I see this quoted in other places as well. I'd say it's a good starting point. Then we go to recommendation number 2. In adult emergency department patients with alcohol use disorder, they suggest the prescription of an anti-craving medication for the management of their alcohol use disorder for patients who would like to stop using alcohol. This is something I'll admit I've not done very much of in the past, but definitely should be doing. If they'd like to quit, then these are drugs that can definitely help them. They went on to make recommendations 2A, 2B, and 2C to say that if your patient is not taking opioids, that naltrexone, compared to no prescription at all, should be the first-line choice of helping patients quit their alcohol use disorder, and it had benefit to preventing return to heavy drinking. So that's nice to see. If there were some contraindications to naltrexone, probably opioid use, then acamprosate was sort of the second-line use. Now, on top of the anti-craving medication, you could also add gabapentin for the minority of patients who might require some help with cravings. They kind of make this one extra conditionally, and they say that you should only prescribe it for maybe 2 weeks as a bridge to getting these patients, hopefully, for follow-up with addiction services. As for the naltrexone or acamprosate, they say you should prescribe this for at least 4 weeks as kind of a bridge for possible continuation by the patient's primary care or addiction services. Hopefully, you're able to secure follow-up for these patients so that they can have some more help with their alcohol use disorder. Again, they do like to stress that there are a lot of sedation properties with gabapentin, so you should be only giving this kind of sparingly and carefully. Lastly, they had recommendation 3A, which was in adult patients presenting to the emergency department with cannabinoid hyperemesis syndrome. They suggested the use of haloperidol or droperidol in addition to your typical treatment for nausea vomiting like ondansetron to help with symptom management. Again, this is very low certainty evidence. They even added another recommendation that they suggest offering the use of topical capsaicin as an adjunct to those treatments as well. All right, how's this going to change my practice? Well, I'd say that adding phenobarbital to benzodiazepines seems like a good strategy. If you can add the phenobarbital, maybe just do your opening dose as 10 milligrams per kg, and then if they require further care, you do benzodiazepines on top of that. It's probably a pretty good strategy. Alternatively, you could also just still add more phenobarbital, but it's going to be up to you, perhaps your hospital protocols. As for alcohol use disorder, well, I'm going to make a concerted effort to try to prescribe more naltrexone, possibly acamprosate to these patients, and in the minority, maybe some gabapentin as well for help with cravings. And then there's cannabinoid hyperemesis syndrome. I personally was already treating these patients with haloperidol as well as my first-line drugs for vomiting, so not much is going to change for me on this one. I might consider slightly more strongly capsaicin cream, but I don't think we even have that in our pharmacy, so I might not end up doing it. In spoonful, these were the GRACE-4 guidelines, which commented on some really relevant stuff to us in the emergency department, and this is a 31-page document that has way more to say than what I summarized, so I recommend you reading it yourself because it was well-written and it was relevant. And then we skip to the 5th article, titled Implementation, Clinical Benefit, and Safety of a D-dimer-focused pulmonary embolism testing pathway in the emergency department out of the Annals of Emergency Medicine. No doubt all of you are extremely familiar with what seems like dozens of different ways to handle testing for PEs in the emergency department. There are many, many different algorithms for you to choose from. It's really hard to settle on exactly which one to use. And if you look at rates of actual uptake of these practices, of following these algorithms, you'll see that the literature seems to show that the uptake is quite low. Even though we have all these algorithms, people tend not to use a lot of them and just kind of do their own thing, which is unfortunate because it leads to over-testing, and it's just maybe not the best thing for our patients. What these authors were thinking about was trying to prioritize people uptaking some kind of rule, and they wanted to make it as easy as possible for the maximally, perhaps lazy clinician. What they did was set up testing for PE in these emergency departments, and what you would order was just PE testing, and automatically that would send a D-dimer on the patient. If the D-dimer was positive, more than 500, no adjusting for anything, then boom, they kind of automatically got a CTPA. If the dimer was negative, all right, perfect, you've essentially ruled out PE and go on from there with other diagnoses. They prospectively implemented this in 2 Canadian emergency departments in November 2019 and June 2021. A total of 16,000 patients, either from an external control site, the pre-implementation group, or the post-implementation group, were recruited, and all were suspected of having a potential PE as a diagnosis. What was amazing was that adherence to this very simple strategy was 98%, which is probably better than I've heard of for almost any other implementation of PE testing rules. The strategy only missed 0.04% of patients who went on to have a PE diagnosis in the following 30 days, and this was less misses than in their control group, which were doctors pretty much left to do their own thing. Thanks to the adherence to this protocol, there was less people who were imaged despite negative dimers or without dimers at all. And imaging yield actually increased post-implementation, so more scans that were sent were positive, though there were similar proportions of actual patients tested. Perhaps due to the simplicity of the approach, there was a slightly lower length of stay. So they're definitely ordering more D-dimers because now every patient for sure gets a D-dimer. You're not perking anybody out of anything. And when they do order a scan, they're more likely to actually find something on their scan, but they're not necessarily scanning a different number of patients, so the scanning problem is just as bad. The authors do acknowledge that the other pathways using Years, Geneva, Wells, Perk were more efficient in reducing chest imaging. So this is interesting because if you're really high-risk Wells, we tend not to dimer those patients. However, from this study, it seemed regardless of your pretest probability, having a negative dimer was safe. So I don't think that this is necessarily going to be my go-to approach in the future. But it's nice to know that as a strategy, as kind of a low cognitive load strategy, it's still a legitimate one. So maybe at the end of a night shift, when I don't think my brain is working as well, if I just fire off a dimer and go, okay, it's not a PE if it's negative, then that seems to be a pretty safe approach. So if you just fall to this as your sort of backup strategy, then you're probably pretty clear. Although if you do want to put in a little bit more work, then you can be a little bit more efficient and likely reduce your amount of imaging using all the other techniques which are available for PE testing. All right, in this spoonful, this D-dimer only pathway in patients with suspected pulmonary embolisms was safe. It helped to determine if imaging was needed or not, but of course, there are probably slicker ways to handle your PE patients. All right, so that's all our articles from this week. Let's do a quick review of what we talked about. From the second article, we had the new GRACE-4 guidelines, which were ambitious and helpful, commenting on phenobarbital for alcohol withdrawal syndrome, alcohol use disorder treatments, and the treatment of cannabinoid hyperemesis syndrome. Then from the fifth article, if you just want a really simple life, you can just do a D-dimer on every patient in which you suspect a possible PE. If it's negative, perfect, ruled out. If it's positive, you just scan. No cognitive load involved. However, I still think that you can improve by using some of the other tools out there. Again, if you were hearing this right now, then you were not a part of the member suite. And so you missed 3 articles from this past week. What did you miss? Well, we did a review of mesenteric ischemia. We saw an article that makes you rethink how urine cultures should be ordered. And then we looked at some great evidence for PPIs and gastric protection in critically ill adults. Links to all the original articles can be found at journalfeed.org and just follow the links in the show notes. Our goal here is for you to read less, learn more, and save lives, one spoonful at a time. Thank you.